This is a presentation on Geriatric Syndrome, Falls by Miranda Elliott at East Tennessee State University. Geriatric Syndrome, definition and significance. Falls. A fall is defined as an unplanned descent to the floor with or without injury. Falls pose a significant threat to older adults. It can reduce their ability to remain independent. It is not a normal part of aging. It's important to take steps to prevent falls. 1 out of every 5 falls cause serious injury. 800,000 patients are hospitalized due to a fall, and 3 million older adults are treated in the emergency department for fall-related injuries. Falls are the leading cause of morbidity and mortality in the U.S. They're the leading cause of injury in adults over the age of 65. It results in direct medical costs of $35 billion. Fatal falls are projected to rise to 100,000 per year by 2030 and cost $100 billion annually. Fall prevention strategies are important in clinical practice to prevent these numbers from rising. Identifying risk factors. Providers can help eliminate falls when proper risk factors are identified and addressed. On the right, you'll see the algorithm for fall risk screening, assessment, and intervention. It's a plan of how to assess patients for fall risk and what interventions you need to do to reduce the risk of falling. Conditions that can contribute to falls: difficulty with balance, lower body weakness, vitamin D deficiency, use of certain medications, and polypharmacy. Patients that take more than 4 medications are at risk for falls due to polypharmacy. Vision impairment, poor fitting footwear, home hazards such as throw rugs, clutter in the floor, uneven steps, poor lit areas, absence of grab bars, and things like that. Patient case. This is the subjective data. JW is a 70-year-old male, lives at home alone, and he was admitted to the hospital for a non-STEMI. His health has been declining over the past few months. He resides in Lebanon, Virginia, in a rural community on a farm, lives next to his brother, and he also has 2 daughters that live close by and check on him daily, attends church twice a week, and he denies any recent or former alcohol or tobacco use. Childhood illness include asthma. His adult illnesses are atrial fibrillation, MI, type 2 diabetes, gout, CHF, COPD, coronary artery disease, sleep apnea, hypertension, colon polyps, diabetic neuropathy, black lung, and then anemia requiring a transfusion. He had a cardiac cath with stent placement this year, and he had a hernia repair in 2004 and an appendectomy in 2010. He had a recent hospitalization for an NSTEMI. He was hospitalized several times over the past 5 years for COPD and CHF exacerbations, and 1 other previous hospitalization for anemia requiring a transfusion. He received his childhood immunizations and a flu vaccine this season. He had the pneumovax in 2017, the shingles vaccine in 2018, and he is up to date on his Tdap, but he was unsure when that was. But he denies any other vaccines that he is aware of. Here is a list of JW's prescribed medications: albuterol, allopurinol, aspirin, doxycycline, finasteride, Flomax, gabapentin, metoprolol, metformin, omeprazole, Mirapex, pravastatin, prednisone, primidone, warfarin, Novolog, and Ellipta. Some of those medications can cause hypotension and does increase his risk for falls. Those medications would be gabapentin, metoprolol. The aspirin increases his bleeding risk, and so does the warfarin. His current diagnosis: anemia, COPD, essential hypertension, obstructive sleep apnea, coronary artery disease, diastolic heart failure, restless leg syndrome, type 2 diabetes with diabetic neuropathy, chronic AFib. His current problems, peripheral edema, malaise and fatigue, and COPD exacerbation. Subjective data. Pertinent information for the review of systems with JW. Feeling weak, it has increased fatigue, denies any vision changes or vertigo, does have shortness of breath on exertion, unable to tolerate much exercise. He's currently O2 dependent on 2 liters of oxygen at all times. He denies any syncope or palpitations, denies any dysuria or urgency or frequency. He does report easy bruising, but denies any prolonged bleeding. Has chronic back pain and diabetic neuropathy pain in lower extremities. Reports decreased sensation in lower extremities, but denies no other neurological symptoms. Clinical presentation at risk for falls. So a typical presentation for a patient at risk for falls would be history of falls, unsteady gait, difficulty with balance, altered mental status, and this can be acute or chronic problem, decreased sensation, weakness, poor vision, use of assistive devices such as a cane or a walker, dementia or delirium, taking medications that alter mental status or put patients at risk for orthostatic hypotension, requiring oxygen, urinary frequency, or frequent toileting needs. So JW, he's at risk for falls because he does take medications that put him at risk for orthostatic hypotension. He's currently oxygen dependent. He has weakness and decreased sensation. He does have an unsteady gait and difficulty with balance. Objective data. This is the recent vital signs for JW. 5'9", 315 pounds. His BMI is 46.5, which puts him in morbidly obese category. Blood pressure is within normal limits. Heart rate 63 and irregular. He has chronic AFib. Respiratory rates 20 and regular. Temperatures within normal limits. Oxygen saturation is 95% on 2 liters. Nasal cannula. He is ill-appearing, obese, older male. He does appear a stated age. Awake and alert, no acute distress, normal color, and appears well-nourished. More objective data. Pertinent physical exam findings. He is alert and oriented ×4. Visual acuity is intact, bilateral 20/30 with no correction. Visual fields are intact. Hearing is intact. Diminished breath sounds bilateral and crackles present in the bases bilaterally. Abdomen is soft, non-tender, negative for CVA tenderness. Unsteadiness present with no assistive devices. He was unable to rise from the chair without using his hands, so he wasn't able to perform the get up and go test. He does rise from the chair with slight difficulty using his hands. He did have a negative Romberg and sternal shove sign. Deep tendon reflexes are equal and 2+, and that was in all areas. Patient unable to differentiate from sharp or dull in the bilateral lower extremities. Cranial nerves were grossly intact. The tools that I use for assessment for JW, Geriatric Depression Scale. I did this scale because his wife recently passed away and he is at risk for depression because of loss of a loved one. He scored a 3, so he does not indicate that he's depressed. His frailty assessment was also completed and he scored a 2, which is indicative of pre-frail. His mini mental status exam was 28, which indicates no cognitive impairment. Also did a home safety assessment. Home was relatively safe. There were concerns with the walkways outside. They were uneven and cracked. And the second bedroom, the windows did not open. He scored a 15, which is potential safety hazards that were identified. Morse fall risk scale, he scored an 80, which means that he's an extreme high fall risk, so fall risk precautions should be initiated on JW. Labs we completed were the CBC, CMP, a proBNP, vitamin B12, vitamin D, uric acid, hemoglobin A1C, APT, and PT-INR, and a UA. Because of the edema, we ordered a venous Doppler of bilateral lower extremities, a chest x-ray, and orthostatic vital signs. The goals for this patient, he is currently in a health rehab facility, so we wanted to make goals for him when he returns home. So we educated the patient, evaluate the patient about his fall risk, and reduce patient's risk factors for falls when he returns home. He should be reassessed for fall risk and injury in both the home and the hospital setting. Treatment plan should also include balance and strength training exercises to reduce weakness. He's at risk for falls for a number of risk factors that I mentioned. It's important to eliminate any unnecessary medications, control his diabetes, manage any cardiovascular adverse effects such as orthostatic hypotension, and implement home safety measures. To reduce injury from falls, he should be started on vitamin D and calcium supplements. Differential diagnosis for JW, orthostatic hypotension, which was ruled out after the orthostatic vital signs were obtained, and they were normal. But he should be reevaluated for this because he is on medications that can cause hypotension. Hypoglycemia, that was ruled out because his blood glucose levels have all been within normal limits. Dehydration was ruled out after a normal CMP and UA. Vertigo was ruled out because the patient does not report any dizziness, only weakness. So the final diagnosis, at risk for falling. He's had several risk factors for falling, including weakness, unsteady gait, polypharmacy, overweight, diabetic neuropathy, and home hazards that were identified in the home screening assessment. The challenges and barriers. Types of exercise programs should be tailored to the individual to meet his or her needs and will promote adherence to the program. Support from family, healthcare team, and friends is important to promote adherence to fall prevention strategies. The choice of accepting fall prevention program is dependent on how the patient sees it impacting their physiological and psychosocial well-being. Cultural and social influences should also be considered. Difference in perception of fall risk by the patient, family, and provider is a major barrier in any fall prevention plan. Some older adults may see fall risk prevention as a sign of aging and may refuse the plan if they think it identifies them as growing older. Community resources. The patient's primary care provider should be the main source of information regarding community resources for fall prevention and of activities and groups in the community. The patient may also require physical therapy and occupational therapy in their home setting to identify additional risk factors. The National Council on Aging has provided a list of fall prevention coalitions in each state. I've included the website for that, and the CDC also has some great resources for community fall prevention strategies. Fall prevention strategies in the community can be exercise classes at senior centers, resources at public health departments, home-based services, church-based programs for the elderly, nonprofit organizations, and parks and recreation organizations. Evidence-based programs for fall prevention in the community are Stepping On, which is a community group that focuses on improving quality of life and reducing fall risk. Otaga exercise program, which is led by in-home physical therapist, tailored to aid in strength and balance. And Tai Chi, Tai Chi moving on for better balance, improves balance, flexibility, and mobility and strength training. It also increases self-esteem and decreases social isolation. Health behaviors identified. Patient reports eating well-balanced meals, but he's morbidly obese according to his BMI. He does walk regularly at home. He receives his vaccinations on time. Reports sleeping 6 hours or more at night, adheres to medication regimen, and compliant with diabetes treatment. His social determinants, he has a 7th grade education. He has proficient in basic literacy skills. He's retired. He does not have any financial issues. Lives home alone. He does attend social events regularly. He owns his own home, and home environment is comfortable with adequate plumbing and electricity. He has adequate medical coverage and has primary care physician that he sees on a regular basis. Lives close to his daughters and brothers, who are his support system. Socioeconomic, cultural issues. He does not have any identifiable issues that would increase his fall risk status. Legal and ethical issues. He does have a power of attorney and living will, and his daughter serves as his POA. In my research of this geriatric syndrome regarding falls, I learned how to identify risk factors in older adult patients. Falls increase mortality rate in older adults, and after patients have one fall, they're more likely to have another. It's important for us to reassess patients' fall risk on a regular basis. For Medicare patients, fall risk assessment is done on a yearly basis. It's important to educate older adults on prevention strategies and teach them that falls are not a normal part of aging, and that fall risk factors can be modified to decrease the incidence of falls. And these are the references, and you can click on the link for those. Thank you.